Welcome to Gas, the true story of a toxic train derailment. I'm Ron Scholl. Last time on Gas, we considered what was known about exposure to chlorine gases at the time of the Alberton spill and understood about multiple chemical sensitivity. We now continue with Part 6, Chapter 6, Doctors and Patients. Epigraph. MRL attorney David Potter. I take it that you did not have any physical scarring or marking from this derailment. Engineer Billy Shutter. That you can see with the naked eye? Potter. Yeah. Shutter. No. William Shutter. Deposition. Lucinda Hodges thought local doctors afraid to link illness to the derailment. The doctors would not specifically say that your suffering was from being exposed, she said. I think they were politically afraid for their jobs. In every waiting room in this town, there was a picture of an MRL train engine. Many residents complained of doctors not attributing certain symptoms to the spill or of being misdiagnosed or diagnosed with psychiatric problems. Doctors paid for by MRL influenced diagnoses, treatment, and a patient's medical record. Some patients found help with specialists, and part of that help was simply being believed. After her chlorine exposure, unrelated to Alberton, Glenda Giles found Dr. Richard Nelson, a Billings neurologist who diagnosed her with brain damage, among her many symptoms. Giles: I said, "You mean it's not all in my head?" He said, "Well, it's all in your head, Glenda, but it's your brain that's your emotions." I started to cry because he was the first person to verify that there was something physical wrong with me. Many Alberton victims mentioned panic attacks or anxiety around chemical exposure, a possible indicator for chemical sensitivity. Hodges said Dr. Mary Stranahan of St. Ignatius, who practiced holistic alternative medicine and treated chronic fatigue syndrome and MCS, told her the hard-to-diagnose cases eventually found her. She said she would be glad to testify, but it would be worthless. She knows that MRL would tear her to pieces, Hodges said. Stranahan said some people developed MCS to the point where they can't live a normal life. I think that's what's happened to some of the people in Alberton. The interesting question is, why didn't it happen to all of them? What made some people more susceptible? There is a Nobel Prize in the future, Stranahan said. At the time of the derailment, Missoula had 3 pulmonologists, Dr. William Beckemeyer, Dr. Paul Lunan, and Dr. Thomas Lemire, the latter out of town during the spill. Lunan tended St. Patrick's Hospital, while Beckemeyer covered Community Hospital in Lemire's absence. Initially, both doctors kept busy taking care of patients admitted to the ICU. Beckemeyer, in his early 40s, had one previous chlorine patient before Alberton, who developed chronic RADS after losing consciousness during an exposure. 10 years later, the patient still had daily symptoms and relied on medications, Beckemeyer said. With the Alberton spill, he said, I have patients who have fairly minimal exposure relative to that patient who lost consciousness, who seem to have an equal amount of trouble. Beckemeyer sat on one evacuee meeting panel at the request of MRL. He recalled telling victims that based on his literature review, for most people with a severe enough exposure to be admitted to a hospital, that's a potentially catastrophic event, he said. Those who have lesser exposures may have ongoing symptoms, but it seemed like the majority of people in the literature got past it without permanent impairment. 3 years later, Beckemeyer felt his original advice was correct. Beckemeyer reported 6 to 8 of his Alberton patients developed chronic respiratory problems that lasted beyond a year. Dr. Paul Lunan, over 50 years old and originally from South Africa, worked the emergency room while also seeing about 10 hospitalized patients, including some put on ventilators and 2 who nearly died from pulmonary edema. The Lee father and son exposed on the highway. At evacuee meetings, Lunan recalled, I may well have made a statement that the great majority of people exposed to chlorine do not have serious ongoing problems, based on the literature. Lunan guessed he continued to see 15 to 20 patients 3 to 4 months after the spill. A year after the spill, he no longer saw any, including those originally critically ill. There were a variety of reasons these pulmonologists lost touch with patients in addition to any improving. Many critically injured people on the highway were from out of town. A great many injured people moved out of the area, including for reasons of hypersensitivity. And many patients said they became frustrated with the treatment they received from initial practitioners and sought out doctors who could address chronic, non-classic chlorine symptoms. In Lisa Mosca's interview conducted in 1998, Dr. Beckemeyer said he did not receive any specific information on the health effects of the spilled chemicals from any public agency, such as the EPA. Beckemeyer assured he talked with some experts from around the country who had had previous experience, and obviously there were plenty of textbooks and articles available to review, he said. Most of us know what the acute pulmonary effects of a substantial chlorine exposure are or can be, so it didn't take a lot of legwork or phone calls to find out how to take care of those who are acutely ill. Yet, Beckemeyer added, and nobody has had a lot of personal experience with it, except in places where there's been a major catastrophe. Unlike Beckemeyer, who worked the ICU, Dr. Lunan also initially treated many people in the emergency room at St. Patrick's. I think the pulmonologist in Missoula had adequate training to take care of patients acutely who had chlorine exposure, the soft-spoken Lunan told Mosca. Yet, victim after victim claimed they were never decontaminated at the Frenchtown Evacuation Center or the two Missoula hospitals, including, according to Sam Austin, in the ICU, a fundamental failure of adequate treatment. While the two treating pulmonologists had been relatively inexperienced with chlorine exposure patients, they both concurred from literature reviews that the great majority of people with non-severe exposures would suffer no chronic effects, and that view hadn't changed with their Alberton experience. However, neither physician followed many patients in the long run, nor were involved with post-spill ATSDR studies that did find chronic effects. Mosca asked Lunan if he felt the Missoula medical community had adequate training to deal with chronic symptoms of chlorine exposure, and whether he received any government guidance on chronic injury. I don't recall that I had a discussion with an EPA toxicologist about long-term effects, he said. There are less well-defined and infrequent but known long-term effects, such as the development of reactive airways disease for patients who have had significant chlorine exposure. However, he said, the long-term adverse effects from chlorine are somewhat controversial. Lunan had been part of the key April 21 two-hour conference call that Ellen Leahy held, during which hypersensitivity was discussed and excluded as a criterion issue for general reentry. According to Chris Weiss, both he and Leahy worked with local doctors to give them information on hypersensitivity and RADS. The main local contact was Dr. Lunan. Mosca asked him whether any government toxicologist mentioned the possibility of victims developing chronic sensitivity and what Lunan's understanding of chemical sensitivity was. No one warned me that may occur, number one, he said. Number two, I don't believe multiple chemical sensitivity is a real entity. In his deposition, Lunan said that, in his opinion, so-called MCS patients often had psychological, not physical problems. He also did not believe that exposure to chlorine could cause one to become more sensitive to chemicals and was unaware of any literature confirming such sensitivity. What about long-term sensitization just to chlorine after an acute exposure? Mosca asked. I think it is probably a very poorly understood entity, Lunan answered, acknowledging he had no training regarding chemical hypersensitivity. Beckemeyer told Mosca he'd received no training for chemical exposures, but claimed we are all aware of chemical sensitization. Mosca tried to inquire if the pulmonologist gained new insight from the Alberton exposures regarding long-term effects. Both had acknowledged there was limited information about mass chlorine exposures. Note, Mosca's interviews came before the December 1999 release of the ATSDR Phase 2 results. Beckemeyer said he had limited follow-up with his patients. There are a few who continue to have some irritable airways, asthmatic-type symptoms since that time, potentially related to the exposure. I don't think there's a lot of material in the medical literature about what is the incidence of long-term reactive airways or asthma following a chlorine exposure. So, did Beckemeyer think a follow up of Alberton victims would have been helpful to learn about the long term effects? Absent a controlled study, Beckemeyer said, should someone want to follow up on a number of individuals here and publish information about that, it would also be anecdotal rather than based on science. You can do a retrospective review, but that's not science, he said. But this hardly detracted from the validity of case studies, even where exposure information was lacking. Alberton was a golden opportunity to learn. Wouldn't it be helpful to study the prevalence of problems? Mosca asked. Once again, in the absence of a scientific approach to that, it's questionable data, he said. Beckemeyer was not interested in prevalence data from the Alberton spill not scientifically gathered, while acknowledging that a controlled study was nearly impossible and unethical. With Lunin, Mosca simply asked whether new information on chronic effects of the Alberton chlorine exposure would be helpful to him and be medically helpful in case of future events like Alberton. No, he said, I think considering that it was a disaster and that things are never perfect in an unplanned catastrophe, it went remarkably well, Lunin concluded with satisfaction. In sum, despite acknowledging the limited medical literature, neither pulmonologist seemed to think there was anything new to learn from their Alberton experience. Neither physician followed many patients in the long run, nor were involved with post-spill studies that might have given them insight into the prevalence of RADS or other chronic symptoms. When Mosca concluded her interview with Lunin, he apparently felt defensive when asked if he had anything else he wanted to say. I'm an independent physician, he said. I'm not on the payroll of MRL or anybody else, but my interaction with the people of MRL was actually nothing but positive. However, Lunin later was hired by MRL to be an expert medical witness and conducted reviews of some patients he did not treat. Lunin mentioned that he and Dr. Beckemeyer went to the Alberton School to give an informational presentation at their suggestion and to try and answer questions. That meeting occurred May 1, 1996. I know he did it at the Alberton School, he said, so presumably things were pretty safe at that point. That opinion piqued Mosca's interest because she knew many victims claimed the Alberton environment intolerable to them long afterward. Was it Lunin's impression that it was safe for all people to go back? It was my impression that the people who were better able to judge that than myself had made that decision, he said. On the other hand, a number of patients went back and could not tolerate going back, he conceded. And then it was appropriate for them to not return back, and I advised them to stay out of there for a longer period of time. Since Lunin did not believe in multiple chemical sensitivity, or that exposure to chlorine could cause one to become more sensitive to chemicals, and believed the area was safe, the obvious question was, what could his patients not tolerate? Was it all in their heads? Mosca didn't ask. No agency or MRL brought in a chemical exposure specialist to talk to spill victims. The pre-Alberton literature established RADS as a chronic condition that could develop following acute chlorine exposure, regardless of a patient's prehistory, as could occupational asthma following repeated low-level chlorine exposures. Once established, RADS could be triggered by multiple irritants, what some would call multiple chemical sensitivity, if not the MCS syndrome. Many victims felt they were not informed by local doctors, health officials, or MRL of the possibility of developing chronic sensitivity or RADS. They were mainly assured that the majority of people would recover fully. Subsequently, when many residents returned home and had hypersensitivity, they felt largely disbelieved or ignored by doctors and officials. Poorly informed and lacking guidance, these spill victims had no explanation for what was happening to them, and this fed fear and distrust. Worse, lacking proper diagnosis, they lacked meaningful treatment. The cries of, "How come so many of us have chronic illness?" went unanswered and effectively disbelieved. Some area doctors did believe claims of chronic illness. Dr. Fredrick Mote of Superior was the primary doctor due west of Alberton at the time. He had already treated a few patients with chronic fatigue syndrome and fibromyalgia who also had some chemical sensitivity. If it hadn't been for my interest in fibromyalgia, I probably wouldn't have had anything to say to these Alberton people, Mote told Mosca in 1998. Because of the fact that the majority of the patients that I've seen tell me that their doctors either do not want to treat this disease or don't believe that it exists, they have been looking for someone who's willing to take the time to listen to their problems and to try and give them advice in terms of the possibility of improving their symptoms, he said. The major types of complaints which these patients exhibited or told me about were severe headaches, problems with their eyes being very, very badly irritated, causing pain, and difficulty with vision. These patients had significant problems with difficulty breathing and cough and feeling short of breath. Some people had headaches so severe they blacked out, he said. Mote referred the more serious respiratory and eye problems to specialists, while claiming improvement in some patients with chemical sensitivity with the treatment of temporary drug regimen. He also used alternative medicine drugs with success. Mote believed in chemical sensitivity as a physical illness. Unfortunately, these people have legitimate physical complaints that are brought on by the exposure to these chemicals in their environment, he said. The effects of some of these exposures on certain individuals can last for years. There is no magic cure. It's a matter of certain medications which have been found to be helpful and a lot of counseling for these patients and help them learn to adjust to the problems which they face and give them some degree of hope for the future. Mote was ultimately critical of MRL's handling of medical complaints. Initially, he said, MRL was sympathetic to the problem. However, as time went by, there seemed to be a greater tendency for MRL to try and back out of responsibility and to try and discredit the patients as being hypochondriacs, or as trying to milk the cow, so to speak, and get as much out of MRL as they could. There were a number of patients that I saw that MRL was attempting to buy off to hope that they would disappear and go away into the woodwork. They were offering them what I would consider relatively small compensation. Some of these individuals have resorted to lawsuits and other means to try and get a reasonable compensation for their suffering. Like other area doctors, Mote received no direct information from any health or government official about the potential chronic effects from chlorine or the potassium cresslate. Similar as with Drs. Beckemeyer and Lunin, Mosca asked Mote if he thought the government should have done long-term tracking of the health of spill victims. But this time, she got a very different opinion. Well, I think very definitely that this should have been done, he said. How long did they continue to have problems related to this spill, for example? Mote said that in Mineral County, basically I'm the only one that took any interest in following up on these patients and trying to help them deal with their symptoms and try to help them to get some relief. Dr. Rick Neumeister was a Missoula ophthalmologist to whom MRL originally referred many patients with eye complaints. By the time of the Edgar's trial in 1998, Neumeister had become a treating physician witness for plaintiffs. MRL contended that Edgar's eye problems were unrelated to chlorine. Neumeister cited no scientific studies and gave an opinion of causation based on a temporal relationship, MRL argued, just because Edgar did not have eye problems prior to the spill. The medical literature only accounted for acute temporary symptoms of chlorine exposure to the eyes. It wasn't that studies had shown no evidence of chronic effects, there had simply been no scientific inquiry at all. But Neumeister did offer his own unpublished case studies, his experience of treating dozens of Alberton victims, long before the ATSDR Phase 2 study results that acknowledged chronic eye problems. MRL had reason to fear Neumeister. The ophthalmologist treated some 60 to 70 Alberton victims with chronic eye problems. Neumeister concluded that chlorine exposure can lead to chronic blepharitis, an abnormality of eyelash follicle or accessory oil glands, mebomyitis, inflammation of the oil glands of the eyelids, and dry eye syndrome, abnormal function of tear and oil glands leading to insufficient lubrication, itching, burning, and blurry vision. Neumeister gathered his case studies to show not only some prevalence of eye injury, but new medical evidence. Ignored by Missoula media, Neumeister's findings lay on the forefront of medical science knowledge of the chronic effects of chlorine gas exposure. If spill victims felt frustrated dealing with mainstream medical providers, they were openly challenged in the legal arena, where doctors were used as ammunition against them. While Dr. Loonan thought it unethical to team with Dr. Kilburn in a lawyer-funded study, he hired on with MRL at $300 an hour as an expert witness in the Griffin cases to offer brief summaries on at least 11 patients he did not treat. Fellow pulmonologist Dr. Beckemeyer was a witness only as a treating physician. Presumably, Loonan's opinion would add more weight to the hired armchair experts, since he had treated many victims of the Alberton spill. Almost across the board, Loonan helped contradict plaintiffs' claims of their illness being related to the spill, as well as many other medical diagnoses. Conflict sowed doubt in a jury. MRL also hired various outside medical experts to review medical files and testing data. Dr. Alan Leff reflected MRL's approach to claims of chronic injury. Leff discounted delayed symptoms, chemical sensitivity, and also marginalized RADS and its diagnosis. MRL also hired Dr. Sheldon Rabinovitz, a certified industrial hygienist, whom MRL had brought into some evacuee meetings to help answer residents' medical questions. Like all non-treating physicians, Rabinovitz reviewed records to inform his opinions. MRL also hired Dr. Steve Johnson, an MRL-referred neurologist, against plaintiffs he had diagnosed. In sum, these medical experts primarily used classical assumptions about chlorine behavior to deny chlorine exposures, while blaming any chronic illness on other factors, and denying exacerbation from chlorine exposure, including smoking, coincidence, and, quote, contributing negligence, such as someone choosing to visit home on animal rescues allowed by MRL and health officials. This strategy could be effective if similar claims of post-spill exposures and illness were not corroborated by many other victims, which was why MRL wanted to try cases individually. Notably, MRL's experts opined that plaintiffs even in Alberton lived too far from the spill to have spill-related chronic illness. MRL made much of the fact that the level of chlorine was unknown because measurements were not initially made. Then, using some unreferenced model assumptions about gas cloud behavior, they dismissed claims of significant exposure based on time and distance. In sum, MRL held that plaintiffs had to prove their alleged symptoms were related to a chlorine-only exposure, absent actual chlorine dose measurements and within the strictest interpretations of the limited chlorine medical literature. On the plaintiff's side, instead of using model assumptions about chlorine gas behavior, expert Dr. Michael Nakar, a hired toxicology expert in Ted Lyons' cases, looked at plaintiffs' symptoms to draw conclusions about their chlorine exposure. Based on commonly accepted chlorine exposure symptom charts, Nakar estimated levels of exposure for 59 Alberton plaintiffs. All 59 smelled chlorine, 0.2 to 3.5 parts per million of exposure. 26 suffered mucosal membrane irritation, 1 to 3 parts per million of exposure. The same 26 suffered irritation to the upper respiratory tract, at least 5 to 15 parts per million exposure. 32 suffered chest pain and burning, chest tightness, cough, and shortness of breath, at least 30 parts per million exposure. And 32 were diagnosed with RADS and chronic airway obstruction, at least 5 to 30 parts per million exposure. These exposure estimates reflected the model scenarios as cited by the EPA, ATSDR, and Chris Weiss. A relative latecomer, Dr. Wayne Sinclair became both a treating physician and a plaintiff expert. An allergist, immunologist, and former pediatrician, Sinclair arrived in Missoula from Florida in early 2000. He had accumulated a medical file on chlorine exposure since the 1980s and had testified about sick building syndrome and chemical poisonings, mainly from pesticides. Sinclair believed in multiple chemical sensitivity and that chlorine exposure could lead to chronic hypersensitivity to multiple irritants. Sinclair diagnosed many Alberton patients with asthma or RADS developing from the spill and believed that some Alberton patients became broadly chemically sensitive. He believed that chronic so-called non-classic chlorine symptoms such as gastrointestinal problems, memory loss, and fatigue all related to chemical sensitivity. Sinclair also did not discount neurological problems as arising from chlorine exposure. Dr. Cynthia Lewis Younger's ATSDR-sponsored clinical evaluation in 1999 helped put into perspective some conflicting information coming from the medical experts in the legal arena. Amid all the effort that ATSDR put and didn't put into Alberton, Lewis Younger's findings were among the most meaningful. Lewis Younger diagnosed RADS in patients who returned peak flow spirometry, which had previously gone undiagnosed. RADS, she said, was, as far as we know, a permanent condition. Lewis Younger argued we should change the standard of care. I would recommend that the medical profession change their acute response to chlorine to rely less on pulmonary functions and include peak flow spirometry as part of the evaluation in every case. People who have persistent coughing or shortness of breath after exposure may have developed RADS, she said. All of those individuals should at least be evaluated with the peak flow spirometry. This was essentially a medical bulletin. Everyone exposed in the Alberton spill should have been part of a peak flow spirometry study to detect for RADS. How many others had gone undiagnosed? Unlike some area doctors, Lewis Younger not only felt she had learned something, she wished comprehensive RADS testing had been accomplished for all those exposed. The data not only would have advanced knowledge of the effects of chlorine, it would have helped people in immediate need. Lewis Younger's findings on RADS deserved a headline, but particularly so in Missoula. The tragedy of Alberton illness was compounded by the fact that what new information had been learned was not broadly recognized by mainstream medicine and media, with implications for Alberton victims and future victims of toxic exposure. Along with the findings on chronic skin, eye, and lung problems documented by ATSDR, Dr. Kilburn's neurological findings, and Dr. Neumeister's case studies on eye damage, Lewis Younger's data contradicted generally accepted medical beliefs about acute chlorine exposure and long-term effects. More importantly to many Alberton victims, it helped verify their long-held complaints. ATSDR did not track hypersensitivity or RADS, or study neurological damage. They ignored their own multiple chemical sensitivity questionnaires and filed away Lewis Younger's findings and never studied Alberton again, as if ATSDR really had not wanted to know the true nature and scope of injury from this spill. All of this informed the adversarial legal arena that pit MRL against spill victims. Next time on Gas, the true story of a toxic train derailment, we examine how health officials and health agencies approached issues around chemical sensitivity and how their conclusions impacted spill victims. Until then, this is Ron Scholl. Thanks for listening. This podcast is adapted from the book Gas, the true story of a toxic train derailment. Visit Amazon.com to see the 2-book series. To access support material in the book, such as maps, photos, illustrations, and video links, visit my Facebook page Gas, the true story, or watch my Gas playlist on my YouTube channel at RL Scholl.